Welcome to Flip Your Script, the vodcast from the American College of Lifestyle Medicine that's all about clinicians redefining care through lifestyle medicine. My name is Dr. Padmaja Patel. I currently serve as the president of the American College of Lifestyle Medicine. I'm board certified in internal medicine and lifestyle medicine. I also serve as the chief medical officer at Nudge Health. In just around 15 minutes, we'll bring you 5 key takeaways from leading experts and practitioners who are using evidence-based lifestyle medicine to transform patient outcomes. From practical strategies to success stories, we focus on the how of lifestyle medicine to empower you to make an impact in your practice and beyond. In this episode, we are honored to be joined by Dr. Heidi Prather. Dr. Prather is an attending physician and professor of physical medicine and rehabilitation at Hospital for Spinal Surgery, Weill Cornell Medicine, where she also serves as founder and medical director of the HSS Lifestyle Medicine Program. She previously spent over 2 decades at Washington University School of Medicine at St. Louis, where she held multiple leadership roles and helped establish several pioneering musculoskeletal and rehabilitation programs. Board certified in physical medicine and rehabilitation, sports medicine, and lifestyle medicine, Dr. Prather has served in numerous national leadership positions and was the first female president of both the North American Spine Society and the Physiatric Association of Spine, Sports, and Occupational Rehabilitation. Her research focuses on pre-arthritic hip disorders, the hip-spine connection, gender differences in musculoskeletal conditions, and the role of lifestyle medicine in improving outcomes. She has authored over 100 peer-reviewed publications and is a founding senior editor for PMNR, the Journal of the American Academy of Physical Medicine and Rehabilitation. Welcome, Dr. Prather. How are you doing today?
I'm great. Thanks for having me.
Wonderful. I'm glad you could join us today. So let me start our conversation by asking if you can please share your journey into lifestyle medicine and how has your background in physical medicine and rehabilitation influenced or shaped that path?
Right. So thanks for that question. So my script got flipped. I would say early 2010, 2011. I've probably, as a physiatrist or physical medicine and rehabilitation specialist, I've always practiced musculoskeletal health, and my career has been in academics. And so I've always worked in collaborative programs, and I probably practiced integrative medicine my entire career.
Mm-hmm. Mm-hmm.
But there was the year that my division grew. I founded a division at Washington University. We were growing, we were seeing more and more patients. And I had a leadership change, and I had my biggest year ever. And I would just see this revolving door of patients coming back and back. And we served a lot of rural communities. And so the accessibility to care was not the same for everybody. Biopsychosocial economic factors were very different for the population I was seeing. And one of my most frustrating things was if I could just get them to a dietitian, if I could just get them an educational thing, I'm trying to manage all this, but it would be better.
Yes.
And that year, I had my biggest year. I saw a lot of patients, and I did not feel like a good doctor. I would have a medical assistant that would knock on the door and say, "Get out, get to the next one." And that was the pressures we were under. And I sat with leadership, and it's financial pressures of every institution. And boy, are we going through that now. But it was happening then too. And they said, "Well, you need to see more next year." And I thought, I can't.
Wow.
I'm a doctor, is what I felt internally. And I had been pitching this integrative program. And they're like, "Yeah, Heidi, great." And then the dietitian I had been trying to hire this whole time brought me almond butter. And I'm like, what is this? And why aren't we just having Jiffy? And That's when I went to the first LSM conference and I went, this is the format.
Ah,
This is it, right? They're talking about chronic systemic inflammation. That's
yes.
happening in my musculoskeletal patients, and that's why they're a revolving door. And oh yeah, and some of them actually happen to have metabolic disorders.
Mm,
This is the framework. I've been taught about sleep, but not fully. Didn't
sure.
know as much about nutrition. No one does. That's why a
Right.
lot of us go in this direction. Physical activity, yeah, we're pretty good at that. And we knew about the being social aware of social connections, and we knew about, or we're taught in our basic training about mental health and its impact on your musculoskeletal system and pain, but
Mm,
not where it's collaborating and showing the bidirectional
yeah.
impact of all the pillars. And
Mm,
that's when the whole thing clicked for me. And I thought, if I can start, I'm a pain and function girl, not a lot of money in pain and function. Nice that you did it, not a lot of money in it. But you start to collaborate and show that metabolic health that's causing some of these painful
mhm.
musculoskeletal conditions is linked to their diabetes. And you at ACLM that first year when I got to go showed me that, oh yeah, there's cost savings when you tie it to hemoglobin A1C. I went, ah,
Mm.
there's my financial model.
Yes.
Right? And that's when it started. And so I started pitching the idea to the CEO of Barnes Hospital in 2013, was allowed to go forward with a pilot in 2015, raised money, built a building
Hmm.
in, and Saturday and Monday, the pandemic hit.
Ah,
So it's been a really long journey for me. And my husband had moved to a different university. My husband's an oncology physician, and we both know, are we going to stay? Are we going to try to develop more? And I saw the potential in this model, and I got recruited. Never thought I would leave there, but situations changed, pandemic,
yes.
really changed a lot of things, and I needed to go move with my husband. And Hospital for Special Surgery came and said, I get what you're trying to do.
Oh,
And we
wow.
worked with it. And so I was recruited to actually found the second one. So that flip of the script came when, like, I know I'm looking for this other thing.
Yes.
No, I'm not providing it. I feel like a bad doctor. And my system says, oh, you did a great job, do more. And
Yeah.
but I can't. I'm not, I'm not effective with patients. So when we write papers about it, it's like when I learned about it, it was like the next logical step is to use the parameters of lifestyle medicine and apply it to patients with painful musculoskeletal conditions.
Hmm.
60% of osteoarthritis in this country is phenotyped as metabolic.
Hmm.
60%,
Wow.
right? Right? We've known for many decades degenerative disc disease is linked to many of these chronic diseases.
Hmm.
There are links all over there, but no one's tied it together that the knee OA you have, the swelling you have today, and the sausage you ate last night are related,
Yes.
right?
Yes.
Beauty I have found in this is that there's a big difference between people with a chronic pain syndrome, which
Hmm.
is kind of one thing kind of leads to another, and there's not really a motivation it's whether it's cognitively there or subconsciously there. So no no blame on anybody there.
Sure.
But
Sure.
those folks actually don't do so well with lifestyle medicine because they just haven't gotten to that place where they're in that willingness to change. And when I figured out that whole thing, why didn't I know this for the last 20 years? Why was I so frustrated that Mrs. So-and-so just would never follow through with it has to be me. I have to be doing back. No, what I didn't know is I didn't figure out who was in an active state of behavioral change. And that's what I found out in the first pilot. I had some patients say, oh, can I please join? I'm like, oh my gosh, these are some of the worst and the hardest chronic pain patients. They did great. Other people I
Yeah.
thought should do great didn't. It's all
Right.
about what's internal in that.
Right.
Recognizing that as somebody who sees people with pain was super, super important. There's a big difference. And so I also always advocate for those of us in musculoskeletal medicine, we have got to get in this game because
Hmm.
pain can be that last thing that turns them from I'm contemplating to I bought the tennis shoes, I'm ready to walk out the door, and I'm in active state of behavioral change. We need to be there to open the door wider when they ask us questions. And if you're not a provider yourself, you know where that person can go, because that may be the time they're really ready to manage the diabetes because their knee hurts. They can't
Yeah.
please the child. And so, yeah, that's my story. And
Yeah.
it's been very happy. And I'm, grateful to a hospital for special surgery and seeing the value of it. They knew they needed to do a better job of getting patients healthier prior to surgery. There's not a lot of motives to get people healthy in healthcare systems. But
Yeah.
they saw that as something they wanted to do. And that's where I started the pilot. And I just found out we have very early data accepted the American College of Lifestyle Medicine as a podium presentation this year on
Oh, wow. Looking
what
forward
the
to that.
early 90-day outcomes look like. So I'm very proud of that and very grateful for them investing in it.
Awesome. Awesome. Well, great story for sure. But what's interesting is that I would love to know, how have you aligned the HSS lifestyle medicine program for patients with musculoskeletal conditions with your hospital's broader strategic goals and mission? Because that's the key, right?
It's the complete key. And people say, oh, you're this non-operative doctor. Why are you like playing around with the pre-surgical patients? I'm like, okay, they make money if they do surgery. If
Yes.
they put more people in MRIs, okay. But they're smart, they're leaders. They figured out if I get people healthier, their outcomes are going to be better. I'm going to save money because they didn't get rehospitalized, especially for patients that are in these bundled payment models,
Yes.
right? One infection and they can go down the toilet financially, really. I mean, it can be a real hardship. So, so you align with what that motive was. Their motive is they want to get healthier, and you just need to show them they got healthier. And I was told by an administrator, Heidi, try to find, no one here wants to change, just so you know. You're in New York. You're not in Missouri anymore. And try to find 20 people who want to, change. No one wants to change. Just try to find them and see if you can get anybody healthy. Found 100. Great results. They mandated it. I'm like, where have I landed? They've mandated a lifestyle medicine program. Uh-oh.
Wow.
Who's doing that? So that was very scary because it's like, uh-oh. So I got a call again, same administrator. She's very upset. We had this patient that was canceled 2 weeks before surgery. The patient's upset. Surgeon's upset. Anesthesia's upset. Everybody's upset. What would you do? I'm like, am I in trouble? Is this my patient? No. She goes, what would you do? I said, okay. Well, I looked through the chart. So she's got 5 chronic diseases and 2 are not controlled. I guess I would side with the anesthesiologist. Let's optimize. She goes, no, that's not my question. What would you do? I said, on the fly, I said, well, figure out if she wants to change or not. And if she's in an active state, she'll go right into this intensive program. We built an intensive track. And if they're not, we're going to follow the evidence. Maybe they're in preparatory stage, bought the shoes, haven't gotten out the door yet.
Right.
We're going to marry the fact, going back to that diabetes, swollen knee, and sausage you ate last night are interrelated. And if you work on one, you work on all 3. Give them a one-on-one evaluation, a group program, and then written material about this is what lifestyle medicine, here's what a SMART goal is. We're here to help you if you're interested, come. But if you're not, you let it be. And that's what we did. Okay, Heidi, again, no one wants to change. So how many people are going to be in these 2 tracks? So we call one the selective track, which is I'm kind of selecting what I want to do, which is not a lot. And then the intensive track, which people get one-on-one services and group programming and everything. I said, well, we'll follow the literature. The literature says people in active state of change, we think it's around 20%, and the other 80 are. So we'll man our staff that way. Great. Heidi's small little program. It'll keep going. Great. Check the box. The flip happened. 70-some% choose the intensive program. People want this. They've been looking for it. They've had 2 bariatric surgeries. They've been on GLP-1s for a year.
Wow.
Yeah. I
love it, because this is something I think most people underestimate, right? People are hungry. Actually, they really want this information.
Yes.
Yeah.
And what's unique about, I'm talking mostly about the pre-surgical patient right now, but what's unique, they weren't searching for us right then. They were told they had to talk with us.
Yeah.
Converting 76% in a moment, they didn't know what they were getting into. They're like, oh yeah, where have you been? I've been looking for you for a long time. And I'm like, what? Took me a while to get here. But it's like, and then you tell your administrators that, and now they're like, oh, I guess Heidi's going to need some more staff.
Mm.
That's exactly what's happened. And again, kudos. I'm so grateful to HSS. We've grown and they've let us grow, and they've, access is everything. They understand that if you get that consistent right education, it keeps with your brand, it keeps with your name. They're very proud of that. And they know this is an exceptional program, even though it's not in the traditional wheelhouse of an orthopedic only hospital. So,
yeah. Well, tell me, how can strategic collaboration and partnerships can help scale the impact of lifestyle medicine across health systems and communities? Because you've been able to scale your program.
Correct. So part of that is, especially in a new role at HSS, has been they've been allowed me to build an infrastructure where I can track everything. So every patient that's in the program is in a repository with discrete data. Mm-hmm. So if you ask me who had a total knee replacement and how many chronic diseases they had and how many visits were they in our program and who they saw and their metabolic measures that hadn't before, I have that. So you have to be able to show the data. What was one of the things that really intrigued me in that first meeting at ACLM is like, what other thing would you just give an intervention without taking a baseline and an endpoint to show what the intervention did, mm-hmm. right? And even if the intervention is education,
right?
And that was it, right? And you look in the literature when the education is given, the adherence is poor. Mm-hmm. So that measurement piece has really been and we're still struggling with we're 3 years in and making sure all the data that we can gather is there. But if I know what my costs are, now I can take this outside of surgical population and I can go to that non-surgical population, and I can go to an insurance company and they can say, yes, I'm interested in this. What's a package price for these services? If I know what my costs are, mm-hmm. and I know what some of these metabolic measures are associated with cost savings for them, we can come to a middle ground. My first pitch to an insurance company was in 2014. And about a month ago, someone asked me for a bid. It took 11 years. Confetti did come out of the ceiling in my office that day, but it did happen. And I hope the bid goes through. We'll see. But the fact that somebody said, finally, I want one, we're there. And this is where we can get to a sustainable model. Mm-hmm. The other place we're going into next would be to work with direct to corporations. Again, HSS, I'm fortunate to be here, has many relationships. So if we pick a business that's self-insured and say, do you want us to provide services, again, in a package pricing, now we're getting to that prevention piece. We're getting to that reversal piece. And that's really, really, the focus of lifestyle medicine. Not that this pre-surgical wasn't, but it's just, they're very dichotomous incentives.
Yes.
Right? Okay. One is to get more people through, and one is to keep them maybe from having the knee replacement. I don't know.
Yes. And I understand you'll be presenting at the ACLM annual conference this year.
Yes.
Some of your data.
Yes. Yes. Thank you for accepting it.
Well, it's been absolute pleasure speaking with you today. While we're out of time, I want to thank you for your valuable insights and for generously sharing your knowledge and your passion and expertise. Thank you to our audience for tuning into this episode of Flip Your Script. We hope today's conversation has inspired you with practical insights on how lifestyle medicine is shaping the future of patient care. If you've enjoyed this episode, don't forget to like, subscribe, and leave a comment. Stay connected with us for more episodes featuring clinicians who are rewriting the script on health, one patient at a time. Until next time, take action, make an impact, and keep flipping the script on healthcare. Thank you.